Hey guys, thanks a lot for joining us again. We got the IncellDX crew. They'll just quickly go through all the familiar faces. There's Chris Meda from IncellDX. I think many of the long haulers have. If you don't know who she is, well, you've been under a rock. Dr. Parikh, she's the third person who, a part of the program, the clinical program, and she's the person that kind of has been hiding and lurking in the back, but we got her out today. And then Dr. Patterson, who, again, if you don't know who Dr. Patterson is, then you have a lot of catching up to do. It's really the brains and the whose magic bus we're on. And also thank you everyone on Twitter who found out Dr. Patterson's spirit animal. We determined it was the wild bison. So we are nicknaming ourselves Dr. Patterson and the wild bisons. Anyway, so we got a lot to talk about today with the long COVID program. I'm going to really turn it over to Chris. She's really going to start things out, and then Dr. Parikh will kind of talk a little bit about the telemedicine portion, and Dr. Patterson really talk about some of the research and a little bit more about what he's seeing in the lab. So thank you, everyone. And Chris, the platform's yours.
Thank you. Thank you very much. Thank you. Well, first, let me just say hi to everyone. Many of you I've probably spoken to, and it's been a pleasure and an honor to work with all of you. And today we wanted to start by really going through what we think are some of the key questions that come up when you start to go through our process, registering as a patient, and then getting your results from the lab, and then on to the telemedicine registration. So just to be clear, IncellDX is the creator and developer of the assay, and Dr. Patterson, the brains behind the assay itself, and the company itself developing it. And then from there, we have two separate entities. One is the lab itself, which you interface with when you want to get tested, and you register as a patient, and that then goes on to the lab. And then you have the other entity, which is the telemedicine EMR, Electric Medical Records Company. Now, just to be clear, these are, we're separate from those other two companies, and that is purposeful on our part because we're guided by the HIPAA regulations. We must not be one and the same. So the lab, if we send something to the lab, that's all under HIPAA regulations. And then if then from the lab, when you register with the EMR system, that too is very separate. So many of you will ask me, did you see this? Did you see that? Nope, I don't see anything because I can't and I don't want to, and you wouldn't want me to either. So again, I just want to say that. So with that said, I just want to start through the process, and I hope that these slides will help you and guide you a little bit more, because many of you probably already know this process, but I thought it was important to just walk through it. So you decide you want to get tested, and you go to our website, www.covidlonghaulers.com. And there is a patient section on that website. It says patient registration. And that's where you click the icon that says patient register. And it will ask for your name, your phone number, your home address, and your email address. Then, one of the things I always tell people that I speak to directly, please keep a copy of exactly how you registered your name and your email address, because often the lab will say, I don't have that person, or I don't have that email. And sometimes the person they used a nickname to register, or they used their full name to register. And then they use, as many of us do, we have 2 or 3 email addresses, they used a different email. So make sure when you register that you keep a copy of exactly how you did that. Then we go on to where the lab receives the patient information. Next slide. Now we're at the lab. And the lab will interface with you. They will get your registration, as you put it. You will get, and they will take your email, and they will send you an email from their email, which is LH@innovativebioanalysis.com. LH being long hauler. Okay, and so make sure you look for that extender, innovativebioanalysis.com. Don't look for IncellDX, don't look for Chris Meda. That's not going to happen. It's really this email that it will come from. We have had some issues with this email going into people's spam folders or your junk file or somewhere. And so make sure that you look in all of those folders as well before reaching out. But you can certainly reach out to us if you don't see it. From there, then you will get, if you get the LH innovativebioanalysis.com, you respond to that email and they will send you a series of paperwork. Actually, not a series, but just about 2 or 3 documents. One will be the authorization that you want to move forward as getting the analysis done, and the cost. Now, let me just say, many of you already know this, it's $360. That $360 includes the testing of the assay and the shipping of the sample tube to you, and then from you back to the lab. So that whole $360 is not just for the assay, but it's also the shipping and the tube and the packaging that goes with it. So that encompasses the whole $360. Then it will also ask for your credit card to authorize the actual payment of that. Some people have said, what happens after that? Can I get my money? Yes, the lab will give you a really nice receipt, and it's in the form that insurance companies often see, so they'll know exactly what to do with it. Whether you get reimbursed is really independent. We don't know. We believe that these are not unusual codes that we're using. So, we feel quite confident that you will, but it depends on your insurance company. So I just want to be sure that's clear. But having said that, you will get this form from the lab, and it's a very nice form. Insurance companies know and expect that kind of format, so they'll understand. Then you will move. So now we've done all that. Then Sue, the person that you'll be dealing with at innovativebioanalysis.com, she'll help you find a draw station. Many of you already have a draw station. Your doctor, your PCP is going to draw you, or you have a clinic down the street that's already said they'll draw you, or you have already been using mobile phlebotomy groups. Not a problem. But if you do have a problem, you don't know where to go, Sue will help you find it. She has a real good group of people to help. Next slide. Then you go on to the next step, which is where you get drawn, and then you send that kit back to the lab. Okay, and there's the return label and everything is in the package. You don't have to do anything special. It's FedEx. You can either take it to FedEx or you can have FedEx pick it up, but it is FedEx. You FedEx it to the lab, and then when the lab runs, and right now they're running once every 2 weeks. We hope to get that down to once every week, but we're not quite there yet, but we're moving as quickly as we can. And basically when the tests are done and they generate all the results, you will get now another email, and it says results@knkconsulting.com. Don't look for innovative bioanalysis necessarily. This is where it's going to come. It's going to come results from this email, results@knkconsulting.com. Again, look in your spam, look in your junk folders, as I said before, for the same reasons. If there's an issue with that, the lab has said, please call them. Once you know your data has been generated, call them and they will help you get the results. I just want to remind you that all of these emails are fully encrypted, so you don't have to worry about somebody getting a hold of this information or it going to somebody. You have total control over these results. You dictate, do you want your PCP, your primary care physician, to get these data or not? Or do you want at some point for the telemedicine group to do that? And I'm going to go to the next slide here, and then I'm going to have Dr. Purvi Parikh speak to what happens with the telemedicine. Next slide.
Right. Thank you.
So
oh, sorry. Go ahead.
There you go. Yep. Nope,
I was jumping right in. So yeah, now we're almost done with week 2 of our telemedicine consults. And so most part, I think it's been going fairly well. We have a very, user-friendly platform. And basically, once you have registered, you can click on the telemedicine icon and fill out our online form. And the two key things that we want you to have prior to registering for a telemedicine consult appointment is one, your test results. So the whole process that Chris described hopefully will be done by this point, and a PCP name. So, this physician will help in ordering the medications and the treatment that are recommended to you during your telemedicine visit, and then what will happen is a patient will receive kind of, welcome email from Dr. Yogendra and the Chronic COVID Treatment Center. And, once you're registered and you receive that email, the encrypted email, you can go forward and share your results. Basically, it's very helpful if you have those lab results already uploaded into your patient portal before the telemedicine consult, because then it makes it easy for us as the physicians to review the labs before we meet with you. So that way, it doesn't waste time, and you can spend your consultation time really discussing the results, your symptoms, and what the best treatment would be for you. And then, of course, it's very user-friendly. There's patient schedules set up, and you can sign up for whatever time slot works for you. And a nice feature is you can invite your PCP. So, I've already had a few meetings with patients where their PCP has been present too, and it really helps kind of close the circle. So that way their doctor can ask any questions that they may have. And it really helps make the whole process more efficient. So everybody's on the same page and you can get started on your treatment plan. So that's pretty much, it's very easy flow, but just make sure you have all of those right, pre-appointment things in place, such as the lab results. Your physician don't have to attend the consultation, but they can, and that helps kind of streamline things and make the whole process more efficient.
Right. Next slide. Yeah, and we wanted to just share with you what you'll see when you go into the actual treatment center website. And this is the first, as Dr. Parikh mentioned, you'll see a welcome letter coming through, and then you hit that sign in button. Next slide. And this is the critical one where I think some people have had an issue really seeing what's going on. You put your contact info in, but before you leave this page, take a look at the tabs above. Make sure you have all your documents. As Dr. Parikh mentioned, there are two things you need. One is you need the name of your doctor, and two, you need to upload your data. Otherwise, the doctors don't know how to work with you. They don't have enough information. And then notice the third tab, it says billing and payments. This is where you pay for it, obviously. The one all the way to the right is the one that is very critical. Request appointment. This is where some people have just not seen it. This is really critical. Got to hit that. Then up comes your information and the appointment calendar, and you'll be able to choose time slots that are not filled. So that is the other piece that's really important. Next slide. And then, of course, comes the consult. Dr. Parikh, do you want to speak to this?
Sure.
You all have had more experience.
Yes, absolutely. So, the consult also, it's very user-friendly on this platform. You'll connect with one of the three of us through the telemedicine portal. It'll be a video visit, and we'll discuss treatments one-on-one with you as a patient or with you and your PCP. And then what we'll do is from there, either your PCP can prescribe your treatment or you can work with the COVID treatment center physician. And we have a whole list and network of physicians across the country that can help you in your local region kind of order the appropriate treatment medicine. Next slide.
Right, great. Yes, next slide. So I just was looking before I go into this, I just wanted to share, I think Dee was asking, must the blood be wrapped in ice and is that difficult? First of all, not ice, but 2 cold packs. And the packaging comes all together. So just be sure that you understand that when you get the packaging from the lab, everything will be there that you need. But don't use ice. We had a couple of people do that. Luckily, it didn't, it melted, but luckily the packaging stayed intact. So FedEx did deliver it. But sometimes if they see it dripping, they will not deliver it. So make sure you use cold packs. Thank you. Good question. And here are the reimbursement codes. I think that we went over the last time we spoke on this. And again, the lab will put they're called CPT codes. You know, most labs use the term CPT code, so you'll know this. And as I said, Innovative Bioanalysis will put together a very nice form for you that the insurance companies understand and recognize. Next slide. And then here's the sample report. This is just this is not exactly the way it looks, but you get the point where all the cytokines are listed along with your long hauler score, which is really critical. And I think that's it. I think we were going to have Dr. Patterson take it from here. I saw some technical questions, Ram. If you've been following them, I've been trying to follow as well.
Yes, there's a couple of things that just on the question panel.
Right.
I think someone asked about the medications and sort of how the telemedicine portion works. Obviously, either myself, Dr. Patterson, or Dr. Parikh will get on the telemed, and along with your PCP or any specialist. We've had people that are physicians that have jumped in with us, and they usually really, it helps streamline the process. So we really encourage that. We can send a link, or when you're on the portal, the video link that's generated, there's a share link, and you can send that to your primary doctor or any specialist that wants to jump in on that conversation. What we do is we will type a report, usually anywhere from 24 to 48 hours. We will have a report to you. That is, you will get an email when that report from one of us is done, so you'll be able to download it. Remember, everything that we're doing can't be sent through email or phone calls or text messages, because we are talking about patient data. We are running a clinical practice, and we have to follow HIPAA rules, and we can't be having these information out there. So the reason why we do it the way we're doing. And then in terms of the prescribing and the medications, you know, something we've encountered is not a lot of physicians want to, and that's understandable. They're still maybe not comfortable. They're still trying to get information. They don't know who we are. And what we'll do is we try to interface with them. We try to have conversations. And if they're still resistant, we have a whole amazing network. And I don't even have to tell you guys that. I think we're getting a lot of feedback. There's a Dr. Murphy out in Connecticut who's got multiple states. There's Dr. Michael out in Pittsburgh, Dr. Hilliard in California. And every day, just today, I spoke to another doctor in Southern California. I spoke to another internist in Ohio yesterday, and he wants to have his university start working with us. So we're slowly starting to, you know, I know I make, you know, kind of this reference to the Dr. Patterson's magic bus. It truly is. From where we were about 6 months ago, and I told Bruce, I said, we're getting gaslighted. I mean, with Dr. Patterson and I would, you know, people were hanging up on us. They were not, we got some rude emails. I would text them and be like, can you believe this doctor? And now, I mean, just look at where we are. We have a whole network. All 50 states are covered. And we're working on the pediatric side of things. There's a couple of pediatricians that are working with us, that are talking to us. We got doctors overseas. There's a doctor in England now. So we're slowly, look, we have no media that's following us. We have no PR. We have no one. And this is all driven by the patients. The website, again, God bless Kate Porter for all her work, and, you know, her donating the website, Harry building the website, Kevin Doyle. I know Kevin's on this feed right now. Amy Watson, Karen Bishop. I mean, the list is endless. That you guys have just really, really driven this project and this program, and we're just so grateful for that. So I think those are the, you know, the sort of the main questions. I know that, you know, we're trying to just streamline everything. We are getting literally better every day. And I think there's one more question, something else I want to address about Maravarac. I know there's a couple of questions about that. There are insurance companies are covering that. I posted something on Twitter. There's some sort of subscription plan that you can get on. I think it's like $40 or $50, and it's significantly cheap getting Maravarac. We're getting patients that are a 1-month dose of Maravarac is anywhere from about $55 to $80, which is really incredible. There's some online labs that I'm looking at, seeing if that we can get some cheaper Maravarac, especially for ones that don't have insurance or just don't have prescription coverage on their insurance. We're trying to work with those patients. And I think overall, the last thing I'll just say is that if you don't have a doctor, whether you are working with us or not, at this point, if you are a long COVID patient and you're continuing to get gaslighted by your physician, or they're not listening to you, or they're kicking you out, or they're pumping you up full of benzodiazepines and sending you out, call us. We will get you a physician, whether you work with us or not. That's not important.
Right.
It's the important thing here is we want to get you better. And if you work with us, that's great, because we think we have a lot of data. Dr. Patterson is about to talk and kind of just drop the hammer, and I know all of you guys are excited about what he has to say and all the things. But we're building this is not a lab test. We are building a program, and we are going to do everything in our power to take care of you and make sure all of you guys get better. So with that being said, I didn't want to say anything much, but I guess I did. I'm going to turn it over to Dr. Patterson. Oh, Chris, yeah.
One more thing, just because this came up on the feed, and also this morning from a patient. One patient asked, "I don't want my data sent anywhere else." I said, "This is an electronic medical record format. That data only goes there. You're the only person that can access it." So I just want to be sure that everybody hears me when I say that. We're not spreading this data anywhere else. No test results. Nothing goes anywhere. It stays right at the EMR site. So that's why we're being very cautious about that. And the second thing I wanted to just hook on to what Dr. Ujendra said, and that is that it is because of you that we really have gotten the visibility. And to that point, I want to tell you that your colleagues in Europe and the UK have also jumped on, and they are helping us. We're actually getting ready to do a pilot in Europe on the mainland, and then we will also do a pilot in the UK as well. So it's because of your long hauler colleagues around the world, really, that we're getting the visibility. And I want to thank all of you for helping with that, because you're going to help your colleagues also get better. So thank you.
So finally, the last but not least, Dr. Patterson. I know all of you guys are sort of waiting for this moment. So Bruce.
Well, again, I'd like to thank, first of all, our team has done a tremendous job getting this launched. We are definitely in our own learning curve, and we're working every day to get better at doing our job to help you get better with the condition that you're fighting. And to that end, I think, as Purvi said, I think we have been successful, and I think the telemedicine portion has been really awe-inspiring for me, hearing the different stories and hearing and seeing the faces of the individuals that we're trying to get better. And like I tell all of them, I think we can get them better. At least in my appointments, I'm seeing patterns that I recognize time and time again. Even though everybody seems to have different symptoms, there seems to be sort of a recurring number of themes. And I just want to reiterate the fact that we aren't treating symptoms. As Ram suggested, we could give you medications that just make you feel good or put you to sleep and say, you'll get through it in 6 months, and we'll just snow you, and you'll feel better eventually. But the fact is, we've identified mechanisms, and all of our treatments address mechanisms. There's other programs that try and throw drugs against the wall and see if they stick, see if they make you feel better, with really no underlying understanding of how long hauler disease works or the condition works. And I think that's why it's been us to understand from a scientific level exactly what is going on in your body and how can we best treat what's going on. And clearly what we've been working on for the last literally almost a year, since last June, we've really gotten to the point where we've really narrowed this down to the fact that there's vascular inflammation. In fact, I just finished taping my talk for the American Association of Immunology 2021 conference that's coming up I believe it's May 13th, conference that features Anthony Fauci and others. But at that conference, I'm going to talk about long haulers, talk about the variety of different tests we use in addition to IncellKine, and I'm going to really reveal the underlying cell types that are affected that still carry COVID protein, 15 months after the initial infection, and what they're doing in terms of causing this widespread vascular inflammation. And really the drugs that we're using are to keep these cells from mobilizing. As I was writing this most recent paper, I was struck by the fact that there was 2 papers already in the literature about this cell type being mobilized by exercise. And I haven't heard one long hauler say that exercise doesn't make them worse. And then there's programs around the country that propose to be long hauler treatment facilities that are proposing physical therapy and activity and exercise, and frankly, nothing could make matters worse in this critical period of time when we're considering treatment. That's not to say that you won't get back to exercising. That's everybody's goal. But the fact is, this cell type that still carries some protein is mobilized by exercise, and then it has a propensity to bind to blood vessels and cause inflammation all over the body, including the brain. So that's what we're really trying to address, is the underlying cause, and do what's best, knowing at least what we think is the underlying cause. And as time goes on, we get even more information and to show that I think we're definitely on the right track, and I think we know what the underlying cause is. And that's really exciting for me to be able to talk about that at an international conference in just a few short weeks. So that's the basis of what we're doing here. We're treating the cause. We're understanding the cause. We're feeling the pain of all the people who are suffering and are debilitated, and what they're going through on a day-to-day basis. And that's what's really driving us, not only to keep on treating, or, we're not just trying different things and hoping one of them works. We are really trying to address, by looking at precision medicine, looking at the various assays that we are running, to decide what is it that's causing the symptoms that each individual has. And even though the IncellKine assay is launched, it's not the last test that's launched. We're expanding to new labs around the globe, frankly. And we're going to be adding a immune profile at the cellular level by looking at immune cell subsets, which also gives us insights into the cell types that are carrying and bringing COVID protein around the body. So we've already talked to labs about bringing that test on board so they can be ordered in parallel with IncellKine. And then eventually, I think we may have a test in a reference lab other than just at IncellDX, where we're able to follow the load, the antigenic load of the cells that carry this protein. And one of the exciting things we're doing right now is we're collaborating with another company that has some very unique single cell protein sequencing capabilities. I think a lot of people have heard about gene sequencing, and people are gene sequencing the virus to look at variants. But what we're really looking at is the protein that remains in long haulers and is causing a ongoing immune response. We want to know what the amino acid sequence of that protein is and compare it to, the protein that's being targeted by vaccine and various therapeutics, because they could be different. And I think only through experimentation will we know that and be able to predict possibly who may feel better with a vaccine, who may feel worse. We predicted a few months ago that probably more people would feel worse after the vaccine than better. We're still big proponents of the vaccine. At least the way I've been approaching it in the telemedicine is, okay, you know what, let's get you better. Let's see what the correlates are when you feel good, and then get the vaccine. And then when you get the vaccine, if it makes you worse, if it makes you better, we'll deal with it. And we'll deal with it by, again, implementing precision medicine and getting you back to, where you were feeling good. So, that's where we stand on that. And so we're agnostic to the vaccine. In fact, we're promoting everybody should have a vaccine. And I think that's a very clear message. What we're trying to do is mitigate the impact on the long hauler symptoms, or if it does impact the symptoms, how do we get you back to where we had already gotten you so that you're feeling better? So I think those are some of the strategies we're deploying as it relates to vaccines, which are critical for curbing this pandemic. So that's our message. You're going to be hearing more and more as time goes on about the underlying causes. We just had a paper come out in one of the trade magazines on what I used to call, symptom-specific cytokine profiles, where I wrote an article on long haulers. Oh, there it is. And this just came out, I believe, yesterday in the American Society for Histocompatibility and Immunogenetics journal. And that is really the need for precision medicine in active and post-COVID-19. And it is absolutely critical. This is one of the most complicated diseases I've ever seen in my 30 years of pathology, and my fourth viral pandemic. And the fact is, we're not doing enough from a precision medicine standpoint to say, where are you on the continuum of COVID, and how to triage these individuals when they become hospitalized, and target therapy more appropriately based on this continuum. And in this article is the first time I talk about this cytokine flip, which, in the manuscript that's already out there, been peer reviewed and accepted, we talked about, the bioinformatics that we use to separate long haulers and active COVID and normal individuals. And the fact that they were completely separate was driven by, this long hauler index. Well, this long hauler index really was a result of a very dramatic shift in three cytokines when you go from acute severe COVID to being a long hauler. In fact, during the revisions of the manuscript, we found a very interesting fact that we hadn't noticed before, and that was, I believe, 5 out of the severe COVID patients we looked at with a severity score, 5 of them actually registered on the long hauler index. And I looked further, and those were individuals who were, almost 14 to 28 days post COVID infection. And it really raised the issue of, are these patients going on to be long haulers? Because they're starting to take form the immunologic characteristics of a long hauler. So it may be conceivable, because we'll have to look at that even further, that we may be able to predict from the individuals who have acute COVID who may become a long hauler just because of the particular immune signature that we see evolving as they go from active COVID to eventually long COVID. So very exciting. It was exciting to get this article out because the other part of this article was where we actually looked at specific cytokines contributing to specific symptoms. And embedded in this article is where we identified 79% of long haulers having elevated VEGF, and VEGF being associated with brain fog and peripheral neuropathies. So we're putting this all together. All of this gets incorporated into our thinking in the treatment arm of this program for all the long haulers. And so, again, we are not just throwing drugs against the wall and hoping they stick. It is all based on what you see here and in other publications, and will continue to be that. And if we have to evolve based on new data, we will evolve based on new data. But we are going to be a data-driven program. And we are at the heart of precision medicine, tailored to each individual as it should be. So that's my message for the day.
So Chris and Bruce and Purvi, it looks like there are just a couple of questions that sort of seems to be some sort of general questions that people have, and maybe I'll just sort of pose it to everyone on the panel, and then we can, you guys can sort of tackle it. There is something I just want to mention about with Maravrac is, if you guys go on my, I'm getting a lot of the emails. I'm talking to the patients and the physicians about the use of Maravrac, and there's always the things about the safety behind it. If you look at my Twitter profile, I found a bunch of studies that, it is pretty impressive how much data there is. This is a drug that's been FDA approved since 2007. So there's a lot of randomized control trials, studies looking into the safety profile of Maravrac. And I know there's some confusion out there. There's some physicians, some other entities that are sort of bad-mouthing Maravrac, and we're kind of having to go look at the studies, look at the literature. Obviously, Dr. Patterson's got a lot of experience on the CCR5 receptor and in a lot of the inhibitors. But Dr. Patterson, do you just want to sort of comment on, obviously it's something we repeat and talk a little bit about, but it's something that's sort of coming up because a lot more patients are on Maravrac. A lot of them are curious, and if you could sort of chime in on your insights, please.
Yeah. And again, I think it's probably something we should post on the www.covidlonghaulers.com website. Because, as Ram said, there is extensive, large clinical trials, one by the NIH 5-year trial on the safety of Maravrac in HIV positive patients who have to take it every single day of their life over 5 years, and deemed it clinically safe. And in fact, there was a follow-up paper in the pediatric population that it was safe in the pediatric population. Now, to me, the epitome of safety is being safe in kids, right? There's a lot of drugs that are safe for adults that aren't recommended for kids. But when you have safety in kids and a 5-year follow-up study of the safety in individuals who have to take Maravrac every day of their lives for 5 years, and you compare that to us, using Maravrac for 2 weeks or 4 weeks or maybe even longer, but certainly, not even a year, maybe a couple months at most, you can understand that the safety is mitigated, and it's certainly supported by the literature. So yes, I do think it's gotten a bad rap. And it's gotten a bad rap for a long time because there's other drugs in the same class, and I was working on all of them in the early 2000s that, basically were incredible in the HIV population. And all of a sudden, clinical trials were stopped because they weren't safe. But Maraviroc wasn't one of them. And like I said, because it's been around for so long, there's abundant safety data. And frankly, it's being used in cancer. So these are patients who have obviously a lot of other comorbidities with liver, renal, whatever. And, they've been using it for cancer trials. So, I think we'll post those articles because you're right, Ram, as more and more people come on board, we could either keep reminding everyone, which we will do as well, but I think we'll certainly post it on our websites so that everybody can read about it and share it with their primary care physicians.
And I think that's a great idea, Bruce. And I think, we should definitely do that and maybe get that up this week. The other thing too is, and you brought up a great point, Bruce, about, we're off-labeling Medicaid. I mean, look, there's no approved drug for long COVID. I mean, the medical community is still trying to, we don't even know what the term is, post, COVID, long COVID, long haulers, chronic COVID.
The sequelae of COVID-19.
Yeah, there's so many different things. Yeah. And when you don't even have a term for the actual sort of the pathology, it's going to be very difficult to find this what's the approved drug. And there's going to be obviously a lot more research. And what we wanted to do was do the research and treat patients, and being able to take what Dr. Patterson's doing in the lab and seeing in the immunology and make actionable clinical plans is our goal. I can tell you that in 3 or 4 years, there's going to be a really great drug that's going to solve all of this. You take this one pill and you'll be better tomorrow. But you know what? It's not going to make you guys feel better today. And our goal is to try to make you feel better, not today, really in the next couple of weeks. That is our goal. So we're trying to see the tools in the toolbox, and everything we're using are FDA approved. They are medications that we can prescribe, we can recommend. They're not experimental, the FDA is going to one day give. And look, if they do, that's great. But right now, our goal is to get people better today. And along those lines, I want to just mention about, if you are on another clinical trial, you cannot be involved in it just because of the rules and how the FDA works with the clinical trials. But once you are officially off the clinical trial, you're done, then you can contact us, register with our program, and we can work with you. We cannot work with anyone that is part of a clinical trial. I know I've been getting some emails about that, so just wanted to put that out there so we're clear about the messaging, that if you're in a clinical trial, please, finish the trial. If you drop out, then let us know. There's a question, Dr. Patterson, that I think Kate asked, and it's about, we get this question quite a bit, and I get this on the telemedicine. I think a lot of the chronic fatigue, the ME/CFS, fibromyalgia, and it's a question that keeps on coming up, and maybe Purvi, if you want to jump in on that. Oops, my headphones just came off. But we get this thing about, do you think that we're going to turn into this MEC's chronic fatigue situation? Maybe I'll have Dr. Parikh sort of chime in on her thoughts, and Dr. Patterson.
Right. Well,
go ahead, Parikh.
I certainly hope not. I mean, we did see a lot of chronic fatigue-like syndromes and chronic fatigue syndrome come out of the H1N1 pandemic, right? And with swine flu, and a lot of it was thought to be like as a result of the inflammatory process left behind by the virus or the infection itself. So here, yes, that could be a possibility, and already some people are experiencing some symptoms of it. But I think this is exactly why we need precision medicine, right? Because then it may be able to, change that destiny of that pathway of inflammation. If we can target what's going on, get you feeling better, it could break that cycle of inflammation that we are concerned may result in chronic fatigue. And there's so many theories as to why it's happening? Is there viral persistence? Is there a reservoir? Is there continued, cytokine activation? And that's why this work, as well as what all of our colleagues across the country are doing, is very important. I'd be curious to hear what Dr. Patterson says about it, but I think this is exactly what is needed to prevent something like that from developing. Because if we can kind of disrupt that cycle of inflammation now, it's much less likely to turn into a chronic issue in the long run.
Yeah, and again, I think from a virologic standpoint, there are fundamental differences. Chronic fatigue, ME, obviously has been attributed to a variety of different viruses, CMV, EBV, varicella, herpes simplex, HHV6. They're all herpes family virus. That cause a lot of these symptoms and a lot of these conditions. The fact is, they have a true latency phase. Unlike SARS-CoV-2, they have true latency, meaning you get infected by one of those herpes viruses, chances are you have it, hidden in a latent phase somewhere, just like. And then under certain circumstances where you're immunosuppressed or inflamed, they reactivate and come out, and there's actually replication competent virus. I highly doubt there's replication competent virus in long haulers. I mean, I think we found one long hauler who was both RNA positive and protein positive, after a year. But you know what? I highly doubt that it was replication competent. And that's very different than the proposed etiologies for CFS and ME. And that's the big difference, is that those viruses are latent. They may have replication that is undetectable because it's below the limits of detection. And frankly, I think the serology for those viruses is horrible. It always has been. In other words, if you look at IgG and IgM, IgM is worthless for chronic herpes viruses because it's all over the place, very hard to interpret. The best way to do it, we used to do it at Stanford, was to do a RNA to DNA ratio. These are DNA viruses. If you look for CMV or EBV DNA, number one, what cell type, what sample type do you use? Plasma, cells, that's one big question. But the other question is, a third of us have CMV DNA, right? Even a higher percentage of us probably has herpes simplex DNA. A lot of us have varicella DNA and ultimately turns into shingles, right? But the fact is, you don't know that it's active. So what we used to do is look for the RNAs that are made off of the DNA to show activity in CMV, EBV, herpes simplex, and others, and ratio it. And that was a measure of activity. It's the biggest question in transplant. You have CMV, but is it active? Or even in pregnancy, there's a big concern about CMV and birth defects. And so women are tested during pregnancy for CMV, but they test for DNA. And there's a great chance that, they're going to be DNA positive, but it doesn't mean that the CMV is active and is actually getting through the placenta and going to cause birth defects. So there's a deficiency there in the diagnostics for some of these chronic, truly latent viral infections. And I think, the etiologies are different, meaning the underlying mechanisms are different, but, I have no doubt that they present very similarly to long COVID symptoms. Why? Because when I first saw the immune panel on long haulers, first thing that came to mind was they're fighting off a viral infection, right? High interleukin-2, high interferon gamma. Those are type 1 cytokines, classic cytokines involved in antiviral responses. But mixed in with that are VEGF, a measure of, potentially vascular inflammation, soluble CD40 ligand, a measure of platelet activation. So there's some things that are unique to long haulers that you won't see in some of these other chronic viral infections or other conditions such as fibromyalgia, post-Lyme, etc. We can't wait to study those. But for right now, we've got our plate full, trying to get through this pandemic like everybody else is.
Thanks, Bruce. We'll take a couple more questions and sort of ones regarding one about telemedicine. And there was a question about the telemedicine between the three of us and our method. We all come from the school of Dr. Patterson. Let's put it that way. Hopefully that answers your question. We work in sync. We are constantly, I think I talk to Bruce and Purvi and Chris more than really any three human beings on the face of this earth. It's kind of mind-boggling, and along with all the patients. I'm looking at the chat feed. I have everyone's cell phone. And you guys all saved in my phone. It's kind of surreal. But the thing is,
are we on the family plan?
But I know we should, right? We should be on the IncellDX family plan, right?
True.
We can cut some costs.
Great. That's a great idea.
Exactly. I think, what a lot of times when I'm doing my telemed, it's going to be exactly the same thing what Dr. Patterson's saying, what Dr. Parikh is saying, and likewise, we are all seeing each other's notes. We are in the one giant EMR. So if a patient comes to me, asks a question, I can go back and look at Dr. Patterson's note and say, well, this is what Dr. Patterson said, or this is what Dr. Parikh said. And if there is a question, I'll just text them, or they can text me. We are all in sync, and one of us is not doing something the other doesn't know, or something different. We're all literally doing the same thing. It's just, we all have our own busy clinical practices. Dr. Parikh has a busy immunology and allergy medicine practice in New York City at NYU. Obviously, Dr. Patterson is running IncellDX and doing not just only the stuff with COVID, but all the other research that they're doing. And I'm in the hospital too, and have my clinical job too. So we're still, but at the same time, we're trying to create time to dedicate. We understand there's a huge need here. And I don't know, Bruce, Purvi, do you want to just sort of chime in on sort of the telemedicine and what we're doing as a group?
Well, I think the other thing is we all bring something different to the table. I mean, Dr. Parikh brings allergy and immunology. There's certainly aspects, of allergy, potentially mast cells contributing to the pathogenesis in long haulers, and having a world-class immunologist like her part of our group is just fantastic. Dr. Yojendra brings all his knowledge of basically physiology. I mean, that's one thing that's missing from us is understanding heart, lung, physiologic manifestations of long COVID. Heart rate abnormalities, respiratory abnormalities, even drug interactions. The anesthesia physicians were always the most up to date on pharmacology. They were the closest to clinical pharmacologists of anybody in medicine, because they had to be concerned about drug interactions. So understand that, as part of our chronic COVID clinic, that portion is covered. We're always talking about and thinking about, boy, can we give this combination of what if we add on this, or what if we add on that? The first person we go to is Ram and say, hey, can we do that? So I think we all bring our expertise to the table. So it's not just a one-person show on the medicine side. I think it's a very unique skill set that we bring to the table. And I think that's what makes it great.
Yeah, I agree. And just to echo the previous comments, I mean, we're constantly in communication with one another. So even for things as simple as dosing, right? Because The way we dose ivermectin is different than how I use ivermectin every day to treat like strongyloidiasis, but it's very different. So we go through, we discuss it constantly. So again, we're all on the same page. And there's many patients, even in the first 2 weeks, that have seen like multiple of us. So, I saw a patient today that already had consulted with Dr. Patterson, and I was, doing the follow-up, and the same, I've seen Dr. Ram's patients as well. So it's very much a collaborative effort.
Yeah, we had one question from Brandon. He asked, he said, number one question I get, do those cells have a half-life? Okay, great. Thank you. Bruce, I think this is for you.
Bruce. It's a Bruce question.
Yeah, exactly. Bruce question.
They do. They do have a half-life. And I think that's a positive. The half-life of these cells in normal conditions versus abnormal conditions, one can argue, but yes, they do have a half-life, and it's, on the order of weeks, potentially months, but it's not, it's not that long. And I think that's something that's encouraging. We're also seeing now this cell population go down, especially with, different therapies, and especially ones containing Maravirac. We have probably about 4 long haulers who we first detected protein in their cells where it went down after either 2 or 4 weeks of therapy. So, that's certainly something we want to see continue is and be able to monitor that. And again, that's what I talked about before. The IncellKine panel was the first thing we got launched through reference labs, and we'll continue to do that throughout the world. But we probably have 2 to 3 additional tests that will give us even more information as we go forward and start treating more and more long haulers that will add to our armamentarium of information and inform us in terms of precision medicine and therapy.
So we'll just take one more question. I know it's getting a little bit late. And this is a question about the cost of the telemedicine. And how often should people be paying? The thing is, we had to do the telemedicine and set everything up because this is a clinical practice. We have a medical malpractice. We have some overhead that we need to cover. In order to do this, that will, we are putting our medical licenses and our medical credibility on the line here. So we have to take things to protect ourselves. And that's why we have a very nominal fee. And one of the things that I say, if you guys have done a telemedicine with me, and I think this probably also applies to Dr. Patterson and Dr. Parikh, is our interaction doesn't end with the telemedicine. There is, through the portal, you can send text messages. We want to hear from you on a daily basis, how you're doing with the medication. We're interfacing with your physician. So I know that, a lot of other times that, a lot of physicians, a lot of the primary care, they have to see 40, 50 patients. They see you for 5 minutes and you see them 6 months later and you don't hear. And we're taking a very different approach. When Dr. Patterson had this idea about putting this clinic and program together back in the summer of last year, one of the things he told me, was I want to put together a holistic program. I remember that very clearly because that really resonated with me. He didn't say, I want to test the patient. He didn't say, I don't want to just treat the patient. I want a holistic approach. And we want to create something. And I know it's just the 4 of us and obviously people at the staff at IncellDX, but we want to create something that you're going to be taken care of, that it's not like a doctor-patient relationship, but you're going to feel like we're really caring about not just only your illness, but you as a person. We understand the social issues. We understand the financial issues. We're setting up a GoFundMe. It's going to be a patient-led program. We should have that up and running in the next week or 2, where we're going to try to help not only with the test of the cost of the assays, but also some of the medical costs too. We understand. We talk about this every single day. We don't just talk about the science. We talk about all these other issues. And that's just really a testament to Dr. Patterson's vision on building this holistic program. So when it goes back to the cost of it, you can, I think I probably speak on behalf of the team. You can interface with us. We'll continue monitoring. Now, when you get to a certain point where you start to feel better, then you should get your lab works done, because we like to know, why are you feeling better? What needs to be done? And then we can telemed at that point. If you telemed with me today and there's something that doesn't work, or you're not sure about, you're not feeling better, or maybe you are feeling better, call me, call Dr. Patterson, talk to Dr. Parikh, send us an email. We'll talk, we'll sort of have these curbside consultations. But when it gets to a point where we have to do a different reassessment and an evaluation, then I think at that point we can do another official telemed consultation, get another official lab work. And obviously I'd like to get, Dr. Patterson, Dr. Parikh, and Chris's thoughts. And, after that, we'll just sort of sum up the panel for the night.
Yeah, I wanted to chime in for just a second on the assay, or I'm sorry, on the testing. That it is $360 for the first go, but the lab will offers a bundle if you do have to go back for a second and a third testing. So you should talk to the lab. Sue at the lab will give you that pricing. So it isn't $360 each time. That is for sure. So make sure you double check that. As Ram was just mentioning, that, if you've got to go back and get tested again, make sure that you check in with the lab. And I did also want to say, this GoFundMe, we are close. I'm working really hard on this. And it, of course, has to be separate from us. It will be a completely different operation. We cannot be obviously involved in it, but we are helping to get it started and making sure. And as Ram mentioned, it is clearly going to be helped along by the long haulers themselves. So I'm really happy about that. And they'll be helping us with it. So just wanted to point that out.
I also want to add, I know up until now, till we officially launched, a lot of the work was done pro bono by IncellDX, and very thankful that very quickly labs were processed and results got out to the patients. So a big thank you to IncellDX for that as well, because I know it's not it's not inexpensive to run some of these tests. It's not cheap.
Sure.
Bruce, you want to sort of have any final words? And
yeah, I think all those comments are excellent, and I think and we're still running tests. Obviously, we're still doing looking for protein in different cell populations, and if you think this is pricey, then you haven't seen anything. But again, we will also try to offer that and offer it at a reasonable price. I mean, I think just in the last week, we had a really interesting perspective on this, when somebody tried to piecemeal together all the various cytokines and chemokines into a panel in Europe, and the total cost was over $1,500.
Oh, wow.
And it gave us great satisfaction, I think, to know that we're offering something at a reasonable cost, and something that's using standard CPT codes that we know have been reimbursed for other assays that IncellDX makes. So we do think there's a really good chance that reimbursement will come through, depending on the payers. And I think, that said, we tried to price it in such a way where it wasn't outlandish, and we could help the most people at the least possible price. So again, I'm really pleased where that turned out. I'm really pleased where we came in with all of this. And like I said, we're seeing it now with, over 200, maybe close to 300 patients treated already, and some of the success stories that we're hearing, and overall general improvement. So yes, it's satisfying, and it's been a great journey, and we're going to continue working hard.
And just one more point to echo what Dr. Yogendra is saying. A lot of the follow-up we do outside of even the consultation, so you won't be left hanging. And I know, all of us are pretty good at getting back to people right away, even outside of the consultation.
except for maybe me.
That's all right, Bruce. I'll be your parent, Bruce. Did you get your notes done? Did you get your notes done for the night? Thanks, Dr. Patterson. Thanks, Dr. Patterson. Thanks, Dr. Parikh. Thanks, Chris, for putting all of this together. And again, guys, a big thanks to Chris. You know, I know a lot of times we talk about the science, but we would not be here if it weren't for Chris. I mean, dear God, like some of the things that she does in her organization and putting everything together and really keeping us all in check, including me sometimes, because you know, I can sort of be myself, and which Bruce and Purvi know all about. But here's the thing: I think at the end of the day, I think the take-home message is that we are accessible. If you guys are hearing rumors, there's things out there, just come back to us. Look, you guys all have my number. I'm looking at this. I'm like, I feel like I'm hanging out with my friends. That I'm on some sort of like Zoom chat, like chatting with my buddies and seeing everyone here. So reach out to us. You know, Dr. Patterson is working really hard. Parikh out there, you know, seeing a lot of the patients. Chris is doing some amazing work. And, you know, just keep supporting us. We're going to work hard. And if you guys have anything, reach out to us. Also, like I said, if you don't have a physician at this point, you got to have one. And one that is going to be receptive, that is going to be caring and kind and listen to you. And we may not have all the answers today, but these doctors are working with us to find the answers. And every day we're learning something new. Every day we get messages from Dr. Patterson, from, you know, what he's seeing in the lab. And that's really changing our, you know, really our thinking. And, you know, what we were talking about 3 months ago is a little bit different than what we're doing now. And tomorrow is going to be something different. And that constant learning and we're disseminating that information is just so awesome for me. It's personally, it's just been a pleasure working with this group and this team, especially with Dr. Patterson and Dr. Parikh. So with that being said, I also want to say, guys, please go check out Dr. Patterson's Twitter page. We gave him a makeover. I know, by the way, Bruce, a lot of comments on the new lighting.
Finally.
We got new lighting for Dr. Patterson. So you're looking good. Yes. Twitter's looking top notch. Looks great.
It looks shiny. Yeah.
Yeah. No, it looks great. But anyways, guys, thank you so much. Thank you, Chris, for organizing this, and we will see you guys soon. Thank you.
Thank you.
Good night.
Thank you, everyone. Bye-bye.